I appreciate that the disc jockey has discontinued that upbeat music that we were enjoying, and hope you had a chance to mingle out in the foyer. But I mentioned to you earlier the incentive plan that I'm operating under, and so I'm going to have to move this along since the hour has arrived. Dr. Zucker, thank you again for that fascinating and fun presentation. I'm a little concerned that there were only a few of us in the audience that got the reference to the Jetsons, and there were a few of us that did get that reference. Okay, throughout the program today, we're going to dig into some broad themes about health, from the delivery system model to our community access to healthy food and our food chain supply, and how it all impacts us. I just read a report as I was preparing for today that data for the Agency for Health Research and Quality at Health and Human Services found that Americans with malnutrition are twice as costly to treat at the hospital as those who come in well-nourished. In fact, malnutrition is involved in 12% of non-maternal, non-neonate hospital stays, generating an excess of $42 billion of expense. I had no idea that we had a problem of malnutrition to that extent in this country. Our first panel will look at food and the individual, specifically the old wives' tale that food is the best medicine. And I hope there'll be at least a minute or two devoted to chicken soup and its role in medicine so that I can report back to my mother. So let's welcome our first panel, Food as Medicine, Building the Evidence, moderated by Joe Doyle. Joe, if we manage our time effectively, we should have a few minutes for questions at the end. And I'll ask you to please introduce the panel.
Sure, my pleasure. I've been planning this panel for many months now, and it's been one of the more inspiring activities I've been doing, because I really believe that food could be a part of the solution of getting people healthier, and it sort of makes intuitive sense, but we also need to have the evidence that backs it up. So part of this panel is to talk about what research needs to be done to gain that credibility, and then I thought it was most important to bring some inspiring programs here to educate you on what the frontier is in this topic of food as medicine. So I'll introduce the panel now, and then we'll go down and give some remarks. But Ana Ayala is at the end of the panel. She is the VP of Programs at Project Open Hand in San Francisco. And Kartika Palar is a researcher at UCSF who's working with Project Open Hand to evaluate their programs. David Waters is CEO of Community Servings here in Massachusetts, another inspiring program that he'll talk to you about. And Seth Berkowitz, one of the leading experts in the role of food insecurity and how that impacts people's health. Schell Passaretti is the Director of Innovations at Geisinger, and she's helping to lead the charge at their Fresh Food Pharmacy program, which has gotten a lot of attention. And again, I'm Joe Doyle. I'm a health economist here at MIT Sloan who's doing an evaluation of the Geisinger piece. So I think we'll start with, we're going to have the program leaders describe their programs first, and then we'll have the researchers chime in after that, and then we'll have an open discussion and then Q&A. So Ana, do you want to take it away?
Sure. So a little bit about Project Open Hand. We're a nonprofit based in San Francisco and Oakland that provide medically nutritious meals to critically ill individuals and seniors and adults with disabilities. We began in 1985 during the height of the HIV/AIDS epidemic and have since expanded to serve people living with other chronic conditions, seniors, and adults with disabilities through congregate meals, home-delivered meals, medically tailored meals, and our grocery center. We currently provide about 2,500 meals a day. And over the past 5 years or so, we've been participating in several research studies just to help grow the body of evidence showing that our medically tailored meal intervention helps reduce healthcare costs and improve health outcomes. So most recently, we partnered with a few other organizations throughout California that also provide similar medical meal intervention, and went to Sacramento and advocated for our services, and were awarded a first of its kind $6 million statewide pilot to evaluate the impact of our medically tailored meal intervention across 7 counties in California. The intervention targets participants who have congestive heart failure and who are high utilizers of inpatient or emergency room services. The goal of the intervention is to reduce readmit rates, and services are entirely free to the patients and are being paid for by DHCS, who's administering it on the state end. And during the duration of the intervention, clients will receive 100% of nutrition services, so 2 meals a day plus a grocery bag, 4 MNT sessions, medical nutrition therapy sessions with our registered dietitians. 2 of those are in person and 2 of those are over the phone. And also information and referral services to kind of help address some of the other social determinants that might be impacting their health. The evaluation method is still in design phase, but it'll be over the 3 years that DHCS will do a match set evaluation against their claims data for CHF patients of theirs against those in the pilot, and a third party will be doing that evaluation. That's a little bit about what we're doing right now. Very exciting.
All right, fantastic. So I think we'll go to the next program again, and we'll go back to the researchers on the second path. So let's talk about community servings.
Sure, thank you. And so exciting to have everybody here. If you have not been to community servings here in Boston, we'd love to have you come see it firsthand. But Project Open Hand is our sister program in San Francisco, and we do very similar work. Here in Boston, we are feeding about 1,300 people a day who have critical and chronic illnesses and can't shop or cook for themselves or feed their families. I think when you think about food in the context of healthcare, we face 3 challenges. The first is that sick people have no appetite. So if you bring them institutional food, what I call my high school cafeteria food, they're not going to eat it because it's not appetizing. So all of our food is made completely from scratch using local farm produce. We make our own soup stocks. We're not using cans of anything. The second is that different people need different kinds of food. And having grown out of the HIV world, we started to tailor meals in that arena. But with a variety of different illnesses, a program like ours, as you can see on the slide, offers 15 different medical diets. But what's most unique is that we can layer 3 different diets in the same meal. So beautiful food, scratch-made, but can control if you have diabetes that's led to kidney failure and you had a stroke, we can control for glucose, potassium, phosphorus, and vitamin K all in the same meal. No matter how talented you are as a chef here in the room, I would challenge any of us to do that. But if you think that you're low income, you're sick, you can't get off the couch because of chemo, you've got 2 kids, you've got unstable housing, you have no food in your cupboard, you have no money, you don't speak English, you don't know how to read, how are we going to do that? And those are the folks who become super utilizers or high cost, high need patients. So that's what we're able to offer them. And then the third is, and particularly appropriate here today, is how do we prove an ROI for that? How do we prove that this makes sense? So a program like Community Servings, we went to healthcare leaders about 5 years ago and said, we think you ought to pay for this service. What would it take to justify that? Because previously we'd been funded through philanthropy or government HIV dollars, and we could never meet the demand. We're always carrying 100 to 150 people on a waiting list. And we serve 21 cities in Massachusetts, which is really exciting, but there are 300 communities in Massachusetts, and we're the only program in the 6 New England states. So with the need to want to feed more people came, what's a new revenue source? And if you're in the healthcare world, you can say, whoa, you're anti-hunger. We're not going to feed everybody. So we said, well, what would it take for you to do that? And they said, you'd have to prove an ROI. So Community Servings was blessed to meet Dr. Berkowitz when he was at Mass General. And we set out to prove that ROI, specifically looking at insurance claims data for patients we'd already fed, and looking back to see how the costs changed while we were feeding them. And what we saw, not to steal Seth's thunder, but what we saw was a 16% cost savings. And when you think of these are the high cost, high need patients, 16% is a big number. Specifically, it was less ambulance usage, less ER visits, and less hospitalizations, all of which just really makes sense if you think of you can't control your diet. We have a patient who every month when her SNAP benefits, her food stamps ran out, she would pick up her A1C levels for diabetes would go out of whack. She'd pick up the phone and call 911. The ambulance would come, pick her up, take her to the emergency room, stabilize her, and take her home. In the first 6 months on our program, she never called 911 once. So you get a sense of where the savings is for something as basic as food. We're looking for those, the holy grail of how to save healthcare costs, and I would posit that it starts with something as simple as food. If we can figure out how to bring it to scale and keep the quality up, which is what I think a nonprofit food program is particularly focused on, we can start to bend the curve on costs and treat people with the dignity they need if they're passing out of life or they're going to recover. Shouldn't there be someone there to say hello and you're not forgotten and here's a beautiful meal?
Yeah, these are really inspiring programs. So we'll go to another inspiring program for the Fresh Food Pharmacy at Geisinger. Shelley?
Thank you. So Geisinger's Fresh Food Pharmacy opened its doors approximately 1.5 years ago. And it was really built on the premise that food could be medicine. We really started to work in this field as we gained a deeper appreciation of just how profoundly an individual's health is impacted by social determinants of health, and in addition to our rising food insecurity and diabetes rates. So we piloted a handful of patients and developed this program where we had them come into the establishment once a week to pick up food. They would get 2 meals a day for about 5 out of the 7 days per week. We provided enough food to feed their entire family. The clinical criteria for enrollment into the program really was the diabetes, type 2 diabetes particularly. We enrolled adults, and we started with an A1C that they had to have of greater than 7.5. Although we know that some goals are below 7, we just started with 7.5 due to sheer volume and staffing. They come into the establishment, and we have really 4 pillars. So we have the healthcare pillar, which is the registered nurse health manager who focuses on the diabetes education and pathophysiology with the patient. We have a health coach who really provides the education curriculum that we have. We have the pantry coordinator who works on the daily operations of the food pantry. We have the RD, and so her job is to really talk about the dietary needs of that diabetic patient, how carbohydrates affect your glucose levels. And she also creates the recipes based on the available food items that are in that pantry for that week. And then we have a community health assistant. And to some of the points made earlier, the community health assistant, which really then works on another pillar, which is the social needs aspect, and closing that gap is, if we can provide food, but the patient has no transportation to get into our establishment, we have to remove that barrier. Or if we provide food, but they don't have a house to store it in, or they have no mechanisms to cook, the community health assistant really tries to identify what the gaps are and helps to eliminate or reduce those. The other pillar, which is the education piece, we partner with Stanford University's evidence-based program, the Diabetes Self-Management Program. And we also do matter balance, so for the diabetic patients who have ambulatory issues due to neuropathies. And then we also have a tobacco cessation curriculum through the Ayala that we provide. When a patient participates in the program fully, we're seeing about a 20% reduction in their A1C. And if they participate in some fashion of the program, we see about a 10% reduction in the A1C. And then the 4th pillar really is just the food. So we provide, as I mentioned, 2 meals a day for 10 meals per week, 5 out of the 7 days, and we feed the entire family. So they come in, it's a choice pantry. They get to choose lean meats, whole grains, and fresh fruits and produce. And then on the next slide, you can just see this is a patient that actually was one of our pilot patients. So when she enrolled in the program, this is 55-year-old Rita. She's raising her 3 grandchildren. She has a very ill husband who's on peritoneal dialysis. She's unable to work. The majority of her adult life, she has been either uninsured or underinsured. She started with a 13.8 A1C with a weight of 181. 6 months into the pilot program, her A1C dropped to 6.9, weight was 165. We're happy to report that her most recent clinical outcomes are 5.4 and 135 pounds. Thank you.
So like I said, there's plenty of inspiring stories. In fact, I've been down to Pennsylvania to meet with the patients, and they are so thrilled to be in the program. It's a really inspiring program. But I'm going to talk more about that in a minute. I was stealing some time for myself. I think we'll go down to the other end again and talk to Kartika about the research that's going on in California and more broadly.
Great, thank you. I think there's a slide. There we go. Before I get into our work with Project Open Hand, I was asked to talk just a little bit about some of the policy landscape. Anna did such a wonderful job about describing the Medicaid pilot. I really can't underscore how exciting that is, the first statewide pilot of this kind. But Medicaid programs in other states have been innovating on this for some time, primarily in long-term and managed care plans, including in Massachusetts and several other states. So I think there's a lot of interest in seeing what the results of something like this can be more broadly. But I think it's important to note for those of you who don't necessarily know the history that really the most comprehensive and longstanding integration of food and nutrition support into healthcare remains the Ryan White CARE Act, which has covered food, including meals and groceries for people living with HIV since the 90s. When paired with medical nutrition therapy, food support is actually considered a core medical service. And Ryan White is still the only federally funded source of food support for a defined health condition like HIV. Nothing like this exists for other conditions that are actually very much more sensitive to diet. And one way to look at this, I think, is maybe the rest of the healthcare field and consciousness is kind of coming around to where Ryan White already was 25 or 30 years ago, really recognizing the importance of social determinants of health in healthcare and for optimizing healthcare. Moving on to our specific work, and there's a little bit of a timeline here. Since around 2014, although in the planning stages prior to that, our research group at UCSF has been conducting a series of prospective intervention studies with Project Open Hand, really to start to build evidence on the potential impact of medically appropriate food support on health outcomes for three populations, HIV, diabetes, and congestive heart failure. And those are sort of some of those preceding, actually, the California Medi-Cal pilot, and then some of those overlapping and sort of happening in tandem. So 2 of the 3 studies have been completed. Our first study was a very small pilot study, about 70 people, pre-post design, no control group for people with HIV and or diabetes, 2 groups. That was comprehensive nutrition support, so 100% nutrition provided over 6 months. And despite the small size of the pilot, we did observe improvements in a variety of outcomes, food security and diet, but also depressive symptoms, diabetes distress, medication adherence. And in the diabetes group, we did see trends towards lower A1C and lower hospitalizations, although those did not reach statistically significant levels. I want to stop and just looping back to policy, note that this very small pilot study, together with, at the time, the evidence that was out there in terms of interventions, where other pre-post studies or retrospective record reviews really kind of formed the evidence that spurred the California Senate to pass the MTM pilot. So at that point, there hadn't been any randomized trials in the literature testing this approach. Which I find interesting. On another smaller scale, the county of San Francisco also provided some funding after this pilot to fund nutritional support for people with diabetes to Project Open Hand. And so although we would have liked to and still plan to hopefully test in a randomized fashion the impact of this intervention on the diabetes group, we then, our next step was a randomized trial in the HIV group because of an opportunity to receive funding for that from Kaiser Community Benefits. And that study wrapped up in 2017. And although we did not see an impact on our primary outcome, which was viral load, we did see, similar to the pilot, improvements in food security, in depressive symptoms, in medication adherence, and in hospitalizations that were statistically significant. And those results are being written up now. The final study I want to talk about is the CARD study, Cardiac Recovery Through Dietary Support. So this is an ongoing randomized trial to test the impact of heart failure appropriate meals, as well as groceries, on heart failure quality of life as a primary outcome, and as a secondary outcome looking at reducing hospital readmission. One thing that's interesting about this is that this actually preceded by several months up to a year the passage of the Medi-Cal pilot. And at the time when the pilot was passed, it actually was not passed to be specific to heart failure. That was a decision that was kind of made in program, figuring out how to actually test the concept that they had funded. And so now we actually have these two programs essentially in tandem that I think are poised to provide some complementary evidence. So in the Medi-Cal MTM pilot, there is no prospective evaluation built in terms of clinical outcomes. The evaluation, as it stands right now, is planned to use secondary data to look at healthcare utilization and costs, whereas CARDS is poised to test essentially the impact on more clinical outcomes. So I think those together is going to be able to provide some really nice evidence on the impact of these interventions. How am I doing on time?
I think that's good. I mean,
Okay. I can save my comments on social determinants until the.
I'd like to hear your thoughts on it.
Yeah? Okay. So the last thing I was asked to talk briefly about, if there were a few moments, is the relationship between food insecurity and other social determinants of health. Because of course, food insecurity and its nutritional and health consequences do not exist in a vacuum. Poverty is a driving force for food insecurity, and yet while almost all food insecure people are lower income, not all low income people are food insecure. So what are the risk factors? What are the protective factors? What else is going on? I would be remiss not to mention high housing costs and housing insecurity as something that is very closely linked to food insecurity. And I would go so far as to say that interventions addressing housing could be considered food insecurity interventions in a sense. We need to be looking at these things together. And that's not only for financial reasons in terms of the trade-offs in people's budgets between food and housing, but also housing, as it's been mentioned, is necessary in order to cook, store, and utilize food, especially in a healthful way. Finally, I want to mention social support, social isolation, social exclusion. There are non-economic aspects of food insecurity that are really important to address, and I think that sort of effective systems interventions are going to take all of these things into account, if not addressing them directly, need to understand that food insecurity is also in a system and needs to be addressed in a comprehensive manner.
All right, that's a great summary. Yeah, so all these things intersect, and at the HSI, Health Systems Innovation, it's all about systems thinking and thinking about how all these things interrelate, and I think that's a very important point. Yeah. So, Seth, do you want to take over the next part?
Yeah, thank you. After sort of hearing these remarks and about all the different programs, I want to maybe aggregate up a little bit and think about how all of this fits together in some ways. So you guys have heard a lot about the term food insecurity, and people are probably familiar with it, but one way you can define it is uncertain access to nutritious food owing to cost. This is a concept that is measured by the federal government every year. The U.S. Department of Agriculture reports rates of food insecurity in the U.S. every year. In general, around 12 to 15% in any given year of the U.S. population reports food insecurity, which is over 40 million people. So it's not uncommon. I'm a physician by training, and so I think a lot about the relationship between food insecurity and health. And when you think about how food insecurity may be related to health, I kind of think of it in two key buckets. So one is that it may influence the development of certain conditions. So a place where this has been looked at extensively is with diabetes. Food insecurity incentivizes the consumption of cheaper, often highly processed foods, refined grains, simple carbohydrates, things of that nature. And over time, the consumption of these foods has been linked with the development of diabetes. So there's likely a link where food insecurity can directly cause one to develop certain conditions. However, the other way that food insecurity can affect health is through the management of conditions. So think about someone who, say, has colon cancer or breast cancer and is undergoing chemotherapy. It's unlikely that the food insecurity caused them to develop cancer, but to get the full benefit of that chemotherapy, people need adequate nutrition to be able to recover, to heal, for it to work, to kill off the cancer cells, but not cause too much harm to them. And if you're food insecure in the midst of this, it's unlikely that you're going to get the full benefit of treatment. You're likely to do worse while getting chemotherapy while you're food insecure than if you weren't. And so even though food insecurity didn't necessarily contribute to the cancer, it can still impact the management of the condition. And so these sort of two paradigms, the the development of a condition and also impairing the management of a condition are common across a large number of conditions. And basically for almost any health condition you look at, people do worse when they have food insecurity. They have higher healthcare expenses, biomarkers of disease control like hemoglobin A1C or cholesterol tend to be higher. They use more healthcare. And so that's led to people wondering, well, what do we do about it? I think it's probably not that hard to convince people that food insecurity is bad for your health, but knowing what to do about it has proved a lot more challenging. And I think one of the things that's very exciting right now is we're in an era of discovery about what food insecurity interventions have effects on health. And so we've heard about a number of programs here. We have medically tailored meal delivery programs. We have programs that provide healthful food that people can prepare for themselves. One of the most effective food insecurity reduction programs in the US is SNAP, the Supplemental Nutrition Assistance Program, formerly known as the Food Stamp Program, well known to reduce food insecurity, and we're starting to see some evidence that there are health benefits to participating in SNAP as well, particularly seems to be evidence around lower healthcare costs and healthcare utilization. So right now, I think the state of the field is very much in determining what interventions are effective in A, reducing food insecurity, and B, improving health, conceived of broadly. And again, that could be a utilization or cost metric, that could be a biomarker metric, that could be a patient-reported outcome like quality of life or depressive symptoms or something like that, all sort of in the category of health. Because there are so many interventions going on right now, I think we're going to learn a lot in the next couple of years, and I think it's very important that we learn from high-quality intervention designs where we can really make good inferences about what's effective, so using things like randomization when possible, or other econometric techniques, as Joe is alluding to in his opening remarks. Once we sort of get through the phase of determining what is effective, then I think there becomes a second set of questions around what you might call comparative effectiveness. So say you have two interventions, both of which might improve food insecurity and improve health. How do you choose which one? What is the right situation to use one versus another? How do they compare on the cost of the intervention? Is there one that could serve more people for the same amount of cost? Are there situations where, based on the specific condition that people have or the specific circumstances of their social life that they're in, that we need to use one intervention versus another? So these comparative effectiveness questions will be sort of the next level of research. And then finally, I think there'll be sort of key dissemination and implementation questions around who is best suited to deliver these interventions? Is this something that comes from within the healthcare system? Is this something that is a partnership between healthcare systems and human services agencies? Does there become a new workforce or a new sector that is specialized in developing and delivering these types of interventions? So I think there's a lot still to be learned, but there's a lot of promising work going on right now, and I think our task will be to do that in a way that we can really form an evidence base and then continue to build on that over the next 5 or 10 years.
Yeah, that's great. And actually, could you just walk us through a bit about what you studied with community servings in particular?
Sure. So I've been very fortunate to partner with David and community servings on a few studies now. And some of the specific findings we found around medically tailored meal delivery for people with serious chronic conditions, as David has alluded to, is that we see impacts particularly in the healthcare utilization space. So we see things like reduced healthcare utilization, fewer inpatient admissions, fewer emergency department visits. But the other thing that I think is exciting, and this came out of a different study than the one that focused on utilization, but that was focused on people with diabetes receiving medically tailored meals, is things in the improved quality of life space. So people reported that it was easier to manage their diabetes when they weren't worried about where their next meal was coming from, that they had fewer depressive symptoms, that their rates of hypoglycemia, dangerously low blood sugar, which are very scary if you've ever either experienced them yourself or seen a loved one or family member with them, those rates were lower. And all of that together meant that people's experience of managing their illness, above and beyond the biomarkers and the costs and everything else, but how people actually felt about managing their illness was much more positive and much more encouraging. And again, for me as a physician, that's really a very exciting thing to see. I think it's important to think about healthcare costs and healthcare utilization, but at the end of the day, for me, if you can have someone in their office and says, I feel better, I'm less scared about this, I'm able to do it, that's really a big win.
Okay, that's great. I guess it's my turn to speak a little bit. You've already heard from me for a while, so I'm not going to be as long as the others, but I've been down to Pennsylvania to go to their initial pilot site, and just meeting the patients and meeting the staff is truly inspiring. So I met one patient, Tom, who has lost 50 pounds, his A1C's gone down 2 points, and now he's leading some of the education classes that are bringing in other patients. And they listen to him when he's talking about portion size, and he's really inspiring to listen to. And this is it gets me out of the ivory tower and into the real world. I love these field experiments. So the program, we're doing this randomized controlled trials launching, because the program's launching into Scranton, Pennsylvania, and Lewistown, Pennsylvania in the coming year. They can't treat everyone at day one, so we're able to randomize who gets the program first and who will have to wait, because some people have to wait anyway. We're going to structure it in a way that we can then credibly show that it affects their biomarkers or their self-efficacy, how do they feel. Because one of the things Tom mentioned was the first time he ever made the meatloaf recipe, it was amazing. He felt so good about himself, and he'd never really done that before. And this, we might take it for granted, this every day you complete these tasks like making dinner for yourself, but if it's new to some of the patients, then it really changed their outlook on life in many ways. So some of the outcomes we want to measure are self-reported self-efficacy, but also do they make their appointments on time better? Do they adhere to their medication better? Things that we can measure in the data to see that they're actually changing their behavior. I just wanted to make 3 quick points. First, the program, my involvement in it was inspired by an alum, Alistair Erskine, who was the CIO, Chief Information Officer at Geisinger at the time. Now he's at Mass General. And so I met him because he was here on campus, and I said, well, what inspiring programs are you working on at Geisinger? And he immediately thought of the fresh food pharmacy, and that got the ball rolling. It also helped that he was the CIO to get us data quicker than usual. Just inspired by the intervention, which I've already mentioned, and this is why we're here, to try to see if we can improve health in various ways. And then it's inspired by the power of these industry partnerships and research. Really, I think that's so important to team the clinical staff together with the academic researchers in order to design the evaluation so that we learn more about human behavior. So I want to know about habit formation. What does it take to change people's habits? It's very difficult to change someone's diet. But here's a program that provides the food for free, so you're dramatically changing the cost, but also teaches people how to prepare the food. So now you're changing the psychic cost of preparing the food as well. Also, the diabetes self-management classes are very hard to get people to take those up. But if you're coming to a clinic, a feel-good atmosphere where you're getting free food, suddenly the take-up rates are much higher. This combination of the clinic and the food pantry at the same time seems to me is a big deal. And last, the food pantry in general is, there's a stigma attached to going to a food pantry. But one thing I like about the fresh food pharmacy, since your health system is prescribing it and they're telling you, no, you need to go for this, it overcomes a lot of that stigma. And so they can solve food insecurity and overcome some of those psychological barriers, which I find to be fascinating. So that's it for my brief remarks there. We're going to spend the rest of the time with a discussion amongst ourselves and then open it up for Q&A. I guess what I wanted to talk about is on the panel is what are the burning issues that need to be resolved to see this food as medicine approach more and more effective over time. So just one thing that strikes me is that Shelley's program, that the patients come to the clinic to get the food, and other programs you're delivering the foods. Maybe you could talk about the advantages and disadvantages of the different approaches. I'm going to jump in. Or yeah, David, what do you think about delivering?
Thank you. So for our patients, they're too sick they qualify, they're referred by a doctor, we look at their medical information, we prescribe a diet through our registered dietitians, but we also look at mobility measurements or activities of daily living. Can they walk to the store, carry a bag of groceries, or stand a stove? And you would only qualify if you're not able to do those things, because of course you could have cancer or HIV and still go to work every day. Ours wouldn't be an appropriate intervention for you. But with that means that they're very isolated. Most of these people don't have a support network. They don't have friends and family. They don't have the person down the street is bringing them a casserole as you might in your suburban existence. So the act of the driver coming to the door is very powerful to say, you don't see another human being in the course of a week, and here we are bringing you the gift of beautiful food, but also it's a wellness check. That driver is noticing, are you answering the door? Are you still there? Has dementia set in and you're more confused? We can get someone out to check on you. So we think that intervention is really important. The challenge will be as we try to take these interventions to scale is that most of them were modeled on an urban density model. So if you think of the history of HIV, it was primarily people living in the cities. So it was easy to go door to door to make deliveries when we were purely an HIV program. But if we want to serve here in Massachusetts, if we want to feed the Berkshires from a base in Boston, what does that mean if we're going to North Adams or Pittsfield with one delivery and one delivery in Marlborough? The costs are different. So I think that's going to be an interesting thing. We're looking at is it meals that are shipped, followed up with a phone call from a nurse or a dietitian, or can we maintain that initial intervention, which we think is really important?
How about you, Anna?
Yeah, so at Project Open Hand, we do home delivery, but we also have a grocery center on site for some of our other services. And it's a great option to be able to provide clients that are a little bit more able to come in and pick up groceries or meals, that option. It's especially nice when serving such a diverse community in San Francisco is while our menu does provide a variety of meals, it's still not as ethnically diverse as the community we serve. So it's nice that the groceries are an option because it does provide that as well. And with the statewide pilot, it's mostly in urban areas as well. So I do think that there is still this question of how do we serve other communities outside of urban areas that are densely populated that you can easily get to. We see that challenge even between Oakland and San Francisco. San Francisco is a 7x7 city and county, and Oakland is much larger. It's part of Alameda County. So serving those, we even see the challenges of being able to deliver in similar ways. But I think being able to provide a variety of options, whether it's come in and pick up or deliver to you, are both important and essential in this type of work.
Yeah, and Shelley, maybe you could talk about people coming to the clinic, but also rural areas.
Sure. So I think that while it works for our establishment to bring patient in, we're also able to close other care gaps. So if they need their diabetic foot exam or their eye exam done, we make that truly a clinic base where they can come in and get that one-stop shop to get all of those items taken care of. I think all of the programs really takes a medical intervention and ties it to a social interaction. And so while we encourage patients to come in, we're also recognizing when patients do come in, if we see that they're a little disheveled or there's something that is troubling to us, we do make a home visit. So it's imperative that we go in and be the eyes, because I think that oftentimes what's shared with us is very padded, and so then that gives us an opportunity to go in and kind of see what's happening in the home. But for the majority of our patients, they do come into the facility.
And so do you, if I remember right, you do an assessment of their capability to cook, and then you help address that as well?
Yes, absolutely. So it's part of our intake is the very first interaction that we have with the patient. We really explain the program in and of its entirety, and we are really looking for patients that are deeply vested and ready to make a change. We try to say that they're the driver of their own health, and we're just simply a passenger helping them navigate the roads. So when we talk to them, we explain the program in and of itself and all of the requirements, and we have a soft kind of contract where they're aware that they would be coming in once a week to pick up food. They would need to see their primary care providers. They would need to participate in the classes. And then we're also screening them at that point for what their skills are, what some of their limitations are, so that we can build a really individualized plan of care.
All right, Kartika, we were talking before about different burning questions. So what are some that you want us to talk about?
Oh, well, I was actually going to just quickly comment on this topic, just to note that there's another innovative model in the state of California that they're testing on a very small scale right now, but to reach rural people living with HIV in rural counties with medically tailored meals and just medically appropriate food support through commercial vendors, such as HelloFresh, such as, there's many of these types of services nowadays, but linked with an RD encounter and then in-person case management as one possible, approach among many, as you mentioned, I think, having a variety of options. But that'll be something that we're testing as well.
Yeah, different combinations, yeah. How about you, Seth?
So I think, as in a lot of things, the devil is in the details, right? So I think food as medicine as a concept makes a lot of sense, and I think what we're seeing from all these different flavors of types of food as medicine interventions is that there's not going to be a single food as medicine type intervention that works in all cases. And that's not surprising. We don't have just one blood pressure medicine. We don't have just one diabetes medicine. We know that there are some that work better for some people and others that work better for others in different circumstances. And I think what we're seeing across all these things is that there are a lot of factors to consider. There's stuff about the individual and what their capacity is. There's stuff about where they live and what their community resources are. There's stuff about their clinical needs and what is specific to that. And when you have these large combinations, it's not surprising that you're going to need different approaches in different circumstances, but also that there's going to be a fair amount of time that needs to be spent to figure out what those right approaches and what those circumstances are. And there's only so much that can be done a priori. We can think about what might make sense, but I think ultimately it's really going to need to be tested in the real world, in the field, and develop a strong evidence base so that we can know and really implement and say, all right, if you're someone in this circumstance living in this type of area with these skills and these clinical conditions, we think this type of intervention is going to work, whereas that may be different in some other area. And so that's why I think we're in a really exciting time where we're learning a lot about what interventions work in what circumstances. And I think there won't just be a dichotomous answer of this works, this doesn't, but who does it work for? How long does the intervention need to last to work? Are there some things that don't work in any circumstances we should just jettison? But are there others that don't work that well in some cases but work really well in others?
Yeah, I mean, one detail that you just mentioned that fascinates me is how do you get the habit formation to change, and how long would you want to give food to people indefinitely or have a graduation, maybe a booster shot later? I was wondering what your thoughts were on these different approaches.
Well, one thing we didn't mention is how long the patients are getting it. So in our program, you could get our meals program for 2 weeks if you were an end-of-life hospice patient, or 10 years if you had a long chronic illness, but you'd be recertified every 6 to 12 months. But the average is 9 to 12 months. And some payers are thinking of doing a 60-day intervention, which I think would be great. But if you've lived through someone with breast cancer or something like that, you can see that you're not going to bounce back. I had heart surgery, and they said I'd be back to normal in 6 weeks. It was 6 months at least. It's true of most illnesses. So to have a longer intervention, I think, is important. I think the other really burning question is who should get the service, and how do we define that? Right now, it's very random. This nurse refers or this dietitian refers all their patients because they've seen the benefit and they've witnessed it. And the nurse working next to them doesn't refer anyone. So I think what we're pushing towards is both a diagnostic tool for certain illnesses that might say this is when a medically tailored meal intervention might make sense, but also predictive modeling across a whole population of a payer when we're negotiating a contract to say who should get the service and where you're going to see the savings, where you're going to see improved outcomes, and let's enroll them not necessarily automatically, but more systematically than the sort of scattershot way that it's done now.
Yeah, I could imagine it doesn't have to be linear in say, let's diabetics and their baseline A1C. You might have the most extreme A1Cs might be less likely to participate, and then there's a sweet spot, and then the earlier ones, maybe the pre-diabetics is where all the bang for the buck is. Do you guys have thoughts on, for diabetics, where the right place to intervene?
Yeah, well, I mean, I think it'll, I think I think the answer is it depends, right? And so, not very helpful, but I think we can unpack that a little bit. So I think it depends a lot on what are the reasons that, say, the hemoglobin A1C is out of control, or what are the reasons that someone's not doing well with their diabetes. We know that food insecurity overall is actually episodic. So even though, I said before, about 12 to 15% of Americans experience it each year, it's not necessarily the same Americans. And so people often have episodes where they're food insecure and episodes where they're not. So if the issue is purely sort of a financial lack of resources, and people need to be supported through that for a period of time, then it might be a 3 to 6 month period or something like that, and once someone's social circumstances improves, then it gets better. If the issue is lack of knowledge about what the right foods to prepare are or something like that, then there might be a period of time where you can receive meals plus education. You can get some modeling from the meals of seeing, what does a healthy meal look like? How do I prepare this? Then you learn those skills, you internalize them, and you can go on your own. If the issue is that because of your diabetes, you have had an amputation or you have extremely poor eyesight and you're just not going to be able to shop or prepare food on your own, then you may need the meals for a very extended period of time. And I think the same questions will get around what are the right populations to use it in. If you could use it in a pre-diabetic population and prevent that diabetes from occurring, then that might be a huge cost savings, but maybe not all cases of transitioning from prediabetes to diabetes are preventable. And so we might need to learn more about which are the ones that will be preventable and which ones aren't. Similarly, as you alluded to, if you have someone with very extreme diabetes, highly out of control, hemoglobin A1C, very advanced disease, maybe no intervention at that point short of just providing insulin is really going to control things because their body just doesn't make enough insulin anymore. But others, maybe it's just a short-term peak because their diet has been really constrained by financial limitations or something like that. And so again, if you can support them through it, even though they started with a very high A1C, they'll come back down, whereas for other people, insulin is the only thing that works. And so I think there's going to be a lot of nuance for all these circumstances. And I think it certainly makes sense to look for patterns, potentially using machine learning or big data tools to tell us where to invest, but I think it's also going to take really, mechanistic scientific research to figure out what is driving this. How do we really understand what the process is so that we can deploy these interventions in the most intelligent way?
Yeah, I mean, at MIT, we're big into the predictive analytics and using the data to try to guide where personalized medicine, so who should get the biggest bang for these types of programs. But based on the ground, so Anna, what types of patients do you see really respond to it versus the ones that don't? And maybe the ones that don't, are there things that we can do to help them?
Yeah, so with the statewide pilot, it's been interesting. We've been partnering with hospitals and skilled nursing facilities throughout the state, and people are really excited about the pilot. People are really excited about these services being available to their patients, and patients are excited to hear about it. But even so, it's really been a slow uptick, and I think it's just given the fact that it's not a built-in system as of yet, and it's something that we're still working to build as part of healthcare. And that's a tricky piece. I think where we've seen a lot of success with our patients and our clients is where there's real champions within the hospitals that are making those referrals, that have those strong relationships with the individuals that will be receiving the services. So that's been a really, we've recognized that is really important, that linkage at that point. And sometimes it's just tricky. We're dealing with really vulnerable populations with phone numbers that get changed very often, that are disconnected frequently. So being able to build that system is really important for us to be able to keep a consistent rapport and relationship with the patients we're serving.
Yeah, that interaction with the referrals sounds like it's going to be a big deal, especially as it gets to be better known about the impacts, and then it'll be a regular part of the care. How about you, Schell? Where do you see the successes?
I would say that the best patient is the engaged patient. And so, developing tools or technology or ways to keep them engaged and interested in their health. And it's also to make no assumptions. So we've seen patients who, live above poverty level, but they're food insecure because they live in a food desert. And so what we did was about 6-8 months ago, we took the USDA food insecurity screening questions and embedded them in our EHR. And so we ask everyone once a year, food insecurity. And then what happens is our internal analytics filters out those individual patients who have the A1C not at goal, that live within a 25-mile radius of where our food pantry hubs will be. And that's how we outreach to our patients. But one of the questions previously was, how long do we give food? In our experience, it's about $1 per patient. So about $15 a week is what it's costing. So the food is the least expensive part. So if we can keep a patient engaged and interested in their health, they continue to get the food as long as they're food insecure. So that's what we've been doing.
All right, fantastic. Are there other burning questions you guys have before we turn it over to the burning questions from our audience?
Well, I think another, in this topic of what other questions we really need to answer, I think the question about the amount of food, kind of the dose of food, was another thing that we've discussed, and I think is still an open question. A lot of the studies that we've conducted and that have been conducted in the Medi-Cal pilot, that's comprehensive nutrition, 100% of meals. I think you had mentioned, Geisinger as well, you had done that at some point. It's a lot of food. Some people really need that amount of food. A lot of people actually don't need that amount of food, even people who are food insecure and, for various reasons. Even if they might be able to use that amount of food, it may not be, not everybody wants to eat all of their food kind of from one source either. We have to take into account people's preferences. And so I think testing kind of different levels of food support is that, 1 meal a day, 2 meals, 3 meals? How do we know who is likely to both benefit from that level of food and also wants that level of food? So I think that studies to test that are another kind of part of the next wave, I hope.
I have one last thing that I was thinking of, which is, because if you're thinking today about social determinants, Massachusetts led the country around universal health care, but they're doing something equally innovative right now that's just about to launch, which is everybody who's on Mass Health or Medicaid is being pushed into an ACO, an accountable care organization, but included in that are flexible service dollars specifically to fund social determinants. So I think it will be really interesting to see which social determinants are funded and what kind of outcomes they see over time. A program like Community Servings is marketing our service to all of those 17 ACOs in advance of this because we see a tremendous opportunity to feed more people statewide. But I think it's going to be, there is just so much movement towards funding social determinants, both within Medicaid and Medicare Advantage programs. So.
Yeah, and we evangelize the idea of smart piloting. So we're on the cusp of plans starting to offer more social determinants interventions because they're going to get paid for them. And that's the time when you're rolling out a plan to do it in a structured way in order to evaluate its impact. And there's not enough of that goes on, and this is what we're really pushing for as an organization at MIT to try to systematically think about how do we want to roll out these new programs. Because typically you can't serve everyone on day one, just like at the fresh food pharmacy, but you could structure it, randomize it in a way that you could then test the outcomes, which I find to be really, really interesting. Anything else?
Would you like to take some questions?
Sure.
From the group? Okay. We have some staff people with microphones walking down the aisles, and of course, the people in the middle of the areas are going to want to ask the questions. So Joe, you can handle what you can and pass off the tough ones.
That's right.
Good morning. Really appreciate the presentation you guys gave. I mean, I'm the CMO of the Staten Island PPS, and I'm a physician as well, obviously. And the idea of food insecurity has not been a big issue in my household. I'm a Sicilian, and we always had leftovers that lasted several days. But I am sensitive to what's going on here. So it's a two-part question. You had mentioned, sir, that moving the patients over to ACOs, a percentage of the budget was going to go to social determinants of health. So the first little question is, do you know what percentage of the budget is going to social determinants of health? And then the second question would be for you guys at the other end, when you're giving the bags of groceries, are you being culturally sensitive to what groceries you're giving? And if not, let's say it's just a generic bag of very healthy foods, are you providing cooking lessons so that my mom, who may not know how to make bok choy, but would probably guess well, would know how to prepare it? So thank you again for the great presentation.
I'm sure there are people in the room who do know. I don't know what the percentage is. I think that the state is still trying to work out with the feds around the flexible service dollars and what the feds are comfortable with, CMS is comfortable with. But I don't know that it's all been defined yet. On the cultural appropriate piece, we feed a very diverse audience, but we recognize, and because we're doing medically tailored meals, we're not doing ethnic diets, so you couldn't be on if you're a Russian immigrant, you couldn't be on a Russian diet. but you're going to see dishes that are within the course of a week that are appropriate to your diet, to your culture. And then our dietitians are working with you the whole time you're on the program, both in terms of nutrition counseling, but also nutrition education. So there are cooking lessons tied to your particular disease curriculum. So if you have HIV, you can come take a series of classes on HIV and diet, or diabetes and diet, cardiac, et cetera.
Yeah, similarly, we have a team of registered dietitians and staff that are Spanish-speaking, Cantonese-speaking, Tagalog-speaking. So we try to make sure that our classes, our demonstrations on how to cook food, our educational materials are diverse enough to help people use the different ingredients that they receive, that are all medically tailored and pretty standardized. There's not a lot of diversity. We'll get things like bok choy from the food bank and stuff like that. So making sure people know how to use that, making sure people know how to cook with bulgur wheat and what would work for their preferences.
I just want to add actually that I didn't mention during our slides, but with all of our studies with Project Open Hand, we have also conducted a series of qualitative studies to understand actually how participants, what they like about the program, what they don't, what are challenges, barriers, and the issue around culturally appropriate food does come up in two ways. One, I think it is a barrier for some people, especially meals are harder to kind of tailor that way, and so I think that is the value of the groceries together with the cooking classes. So some people said, I had never eaten this kind of food before, but with the cooking classes and seeing how it's done and everything, oh, I've actually learned how to eat, and I think quinoa, it was like, there's a lot around quinoa. I know how to eat quinoa now and liking it. Other people, not so much. Other people said, I really, it's hard for me to eat this food. I know it's healthy for me, but this is not the food that I'm used to eating and kind of want to be eating. And so how do we address that better? And I think, yeah.
Yeah, again, I'd like to repeat, a great session. Great to get a window into the things you guys are doing. I wonder to what extent I'm going to call it acute interventions that you make are really a subset of a bigger food epidemic, the obesity dietary epidemic, where you have 10% of the population diagnosed as diabetics. Is food insecurity a subset of that bigger problem? And are you guys working at all with the more general dietary problems that people face in other economic strata?
Maybe Seth, you want to speak about that?
Sure. So I absolutely think that these things are related, and I mean I think you can think of it as like so in cancer genetics and stuff. They often talk about multiple hits. So it's not just a mutation in one gene that happens and you develop cancer. It's one regulatory protein goes down and then one accelerator factor comes on and things like that. And I think what we are often seeing is people getting the multiple hits of a food system that makes it very cheap make some of the least healthy foods the cheapest and the more healthy foods more expensive. So that's one hit. A social and economic system that means certain groups of people systematically are more likely to face economic resource constraints, and so those things in combination often result in the patient populations that we serve. But that doesn't mean that for many people, even if they only have the one hit, i.e. existing in the sort of current food environment that we're in now, that's very different than the food environment of 50 years ago, with vastly increased prevalence of diabetes and obesity and related things. As well, it doesn't mean that just because there isn't that additional hit for those folks that there isn't a big concern there. I think healthcare systems overall have made some attempt to try to address the overall food system. So for example, medical nutrition therapy, i.e. working with a registered dietitian to determine what is the right diet for your needs, is a covered benefit in, for some conditions, say for example, diabetes, for everyone in Medicare. So there's no cost, or there's no means testing for that. And so there are some things there, but I think there's a lot more that can be done. And I think within the healthcare system, which is sort of seeing the ultimate outcome of this, there really could be a lot more integration with the public health world, and then also sort of the agribusiness and sort of food delivery world as well. And I don't think we're where we need to be with that. So there's some work being done there, but I think not nearly enough.
And I'll just sneak a little economics in. So I see these programs as changing the relative price of eating healthier. So people have their same preferences, but we just change the price. And then once they start eating healthier, the idea is that their habits would change, their preferences might change toward eating that way because they get the information, they understand how to cook the food. And so then you should see a longer term, more sustainable change in their behavior that would lead to healthier lives. So that's supposed to be addressing obesity. And when I talk with the people at Geisinger, one of their goals is to substitute away from McDonald's and toward cooking for yourself and cooking healthier foods. So I can see how that would relate right to obesity. I think we have time for one more question.
Thank you for being here. It was mentioned that those who receive the service, who it is largely dependent on the medical professionals who know about the programs. So I was just wondering what kind of outreach programs or outreach components of your programs there is to get to medical professionals, let them know about the programs, and whether that extends to medical schools and including nutrition as part of medical education.
Go ahead.
Well, I always say that nutrition is the poor stepchild of Western medicine. For years, it's never been taught in medical schools. I heard the Surgeon General, the previous Surgeon General, say at a conference that there was one elective in medical school for him, and it was on a Saturday morning at 8 a.m. And that was his only opportunity as a future doctor to understand nutrition. And yet we know, if you stop and think about it, that just as the air we breathe, the food we put into our system is what improves our health, reduces our health, makes us obese, raises our blood sugar, all of those things. So I think that we're at an inflection point right now. And so conversations like this today, the validation of MIT, or I just spoke last week at the Federal Reserve, people are noticing this. And I think it's really, really exciting, and we have to figure out how to capitalize on it. The other thing that I would say is, just to clarify, is traditionally we usually think of food, your question about diabetes and obesity, traditionally we think of food as a prevention or a public health issue, anti-hunger work is a public health issue. But really the message we're trying to bring forward is that depending on the intervention, it's treatment or prevention. So it's downstream and upstream. But if you're controlling someone's diet who's on dialysis and they're seeing poor outcomes while they're on a transplant list, they're not going to qualify for transplant, et cetera. Controlling their diet for them, if they can't do it themselves, is a really valuable treatment option. And so I think your question is really related to how do we get the entire healthcare system to understand that a prescribed meal could be just as important as a prescribed pharmaceutical intervention.
Maybe, Schell, you can close us out with how do you recruit patients and deal with the recruitment?
So we actually just completed our finalized curriculum, an internship through Geisinger School of Medicine for that very same point. So we'll have some resources there as well. But basically our recruitment, as I mentioned, our EHR fires those two food insecurity questions. But then it was boots on the ground. We went out to every physician within that community practice, provided them a fast box, and really it just came down to providing them the criteria, but making it really, really easy to place a referral, because oftentimes you just get stuck in the technology piece of it. And then patients really self-refer. So the neighbor hears somebody else that's enrolled in the program. And then as we expand some additional criteria, we just started prediabetes this week. And we'll plan on those individuals who had bariatric surgery, but their weights are now increasing, as another pilot group.
All right, well, I feel really privileged that we were able to assemble this panel today, and I hope you'll join me in thanking them for coming.